ahead and get started.
Great. Well, thanks very much, Christy, and thanks everybody joining us today and who'll be listening to the recording. So I'm Dave Reisman. I'm from the Center for Disaster Medicine, Boston, and I work in our emergency preparedness program, and I'm fortunate to be the executive director of the Regional Disaster Health Response System project here that is hosted in our Center for Disaster Medicine. And one of the great parts about this project is our ability to collaborate with Dr. Waller and his team in Nebraska, who we've worked with before on different initiatives. And I think what you're going to see as these projects move forward and as we hopefully expand in the future is that there's a lot of synergy between the programs, and we learn a lot from each other. So with that, I'm going to jump right in. If I can advance the slide. So Christy, there we go. So when we think about the RDHRS here in Region 1 in Massachusetts, our overall mission really is to improve healthcare disaster response planning in the state and throughout our region. And we're fortunate that we're building on a really robust structure. We have a very solid Department of Public Health here and both local and regional public health entities that we're working closely with. And as you'll hear during my talk, there's existing structures in place to manage health response and emergencies. But what's lacking, at least here, is the ability to integrate clinical expertise into the response structure. And I'll talk about that in more detail. So overall, we are trying to take a system that we think is actually pretty good and make it even better. And we're not here to replace necessarily existing structures. Certainly, we're working with our health and medical coordinating coalitions with our Department of Public Health, and we're really trying to build on systems that already exist. So we organized our work into three main goals, and they're focused on building a network first in the state, because that's what we're asked to focus on for this pilot grant project. But everything we are doing with the hopes of being able to expand best practices to other parts of the country, and that's a key part of our project. So building this network of technical advisors and clinical expertise who could provide expert guidance during an event. Second, to establish, we are calling a MEOC, a Medical Emergency Operations Center. This again is building on existing EOCs that exist in our state and in the city of Boston and throughout the area we serve, and I'll talk about that in more detail. Although those EOCs exist, they do not currently have the ability to bring clinical expertise into them to provide direction about some of the specialty injuries we might see, whether they be burns, chemical, pediatric injuries, etc. And then finally, we are working to develop state-level disaster medical response teams similar to the federal disaster medical assistance teams through the National Disaster Medical System. We are extremely fortunate to have a robust and varied number of partners throughout this group. So as you'll see, we've really tried to include just anyone we could think of who is interested in partnering with us and could provide value, and there are a lot. So we have all the level 1 trauma centers in the state of Massachusetts, our Department of Public Health at the local and state level, our emergency management agencies. American Burn Association has played a particularly important part in what we're doing related to burn care. We have the Harvard School of Public Health helping us with metrics development and analysis. All of our HMCCs, all of our regional EMS councils, Senior Care Association, community health centers. And the goal, this is very intentional. We want it to be inclusive, and that I think has worked to our advantage. One of the things that we did fairly early on in the project was send a survey to all of our members. So it ended up being just under 200 people who got the survey, and we got a 60% response rate. And really what we wanted to know from our partnership members was what do they think our main goals should be, and how do they think that we should move this work forward, and what do they think it would take to enhance and improve healthcare disaster response and planning in the state and the region. Not surprisingly, a large percentage of the respondents came from hospitals, as you see on this slide. But we also had good representation from EMS, long-term care, and other groups who are helping to serve in the partnership here in Massachusetts. I just want to go through a few of the top findings. So overall, I think we were very pleased that what we heard from people resonated very well and was closely aligned with our main goals. So people were concerned most about improving overall healthcare system surge planning integrating clinical expertise, medical expertise into disaster response, focusing on the development of EEIs, essential elements of information, to make sure that we're collecting data and able to feed that data up so that people at the regional and federal level are able to make decisions during large events. And lots of other interesting things. But the important part about this slide is that we think that our main goals represent the needs of our members, which is really one of the most important things to us. So when we received this grant, Dr. Lawler and I often joke, because we had the same experience in Boston as I think they had in Nebraska. We were extremely excited, and of course we are extremely excited, but that lasted for about 30 seconds, and then we started stressing out pretty significantly. It's a one-year pilot project, and there's an awful lot of work to do, and we're extremely fortunate to be able to be engaged in this work, and are confident that the output will be certainly worth the work, and hopefully something that assists all of us throughout the country as we plan for disaster events in the healthcare environment. But we had to decide how to organize our work, and in our case, we organized that around 12 subject matter expert advisory groups that represent everything from trauma to hazmat, telemedicine, deployable medical teams. And really important to developing the partnership was making sure that we had chairs and co-chairs for these groups. So we didn't just have partnership staff in my office on these groups. We had really broad representation from throughout the state. And that's happened, and it's been actually really wonderful. We've had more people who continue to ask to join these groups and participate. And the work they're doing is actually impressive and important, and has really, really helped us. So to this point, we're almost halfway through this project, which is kind of hard to believe. But the focus has been on assessing the gaps, developing a gap analysis in each of these areas, and then working to think about solutions to those gaps, suggested improvements that we can work on. I'm going to go through those in some level of detail now, being conscious of time to make sure we leave time for Dr. Lawler's presentation and for questions as well. You will see some common themes in here. I will try to move through these relatively quickly, but to hit on all the important points. So the group looking at surge is trying to think about surge in a bit of a different way, and to think about new ways to monitor surge throughout healthcare systems, in addition to all the ways that currently exist. And one of the ideas that has come up through this work has been looking at the rates of transfers that are refused in the state of Massachusetts at the hospital level, which is not information that we're currently sharing with each other, but is one good data point to measure overall stress on the system. And that's something that we continue to work on, this group continues to explore. It's also been interesting to hear best practices from our partners throughout the state, some of whom we had certainly talked with before, but some of whom we haven't, about how to get to 120% of licensed inpatient bed capacity when we think about surge. And really the sharing of best practices has been one of the really impressive things that has come out of this project to date. So one of the things we did in Boston during the marathon bombings in 2013 was part of our disaster plan is to have our hospitalists and internists in a mass casualty incident automatically respond to the emergency department to take responsibility for our boarders, our inpatient medicine boarders who are waiting for inpatient beds, and basically just get them out of the emergency department to make room. And that worked well for us, and is an example of something that we've been sharing with others. So this group is currently refining these kind of data points and thinking about ways to share them in an online forum in the future, and also thinking about ways that we can integrate telemedicine into surge response in the future. We have a group that is focused solely on trauma, and not surprisingly, they are also really interested in data and trying to assess system stress and overload. One of the potential data points to monitor that has come up in that group is if a hospital trauma center is unwilling to, not unwilling, but unable to get a patient to the OR within 30 minutes, that's a problem on a regular day if we have a mass casualty and need to get a significant number of people to the operating room quickly. And having access to that information in a centralized way would certainly be very helpful. There's work that is ongoing to look at mass casualty incident plans, both within emergency medical services and the fire service, and making sure those are integrated with hospitals in terms of transport and casualty collection, and how loading officers at scenes of mass casualty incidents make decisions about where to send patients. And also really important discussion about the role that community hospitals play in these types of events. So we're fortunate in Boston to have many level 1 trauma centers, and frankly, that was one of the reasons why the response to the Boston Marathon bombing went as well as it did. But really, as we look throughout our state, or if you look into even more rural areas than there are in Massachusetts, community hospitals play a critical role, and we need to think about how we can involve them in the response, and whether that means that they are taking care of patients that they aren't normally taking care of, they're doing damage control surgery in a large event, some of the things that the trauma group is working through. The EMS group, so emergency medical services, this varies a bit by state, but in Massachusetts, we have a large number of municipal and fire department-based EMS groups, but there's an even larger number of private service EMS groups, and the interoperability and relationships between those groups are good, but in terms of situational awareness, sharing information, and making sure mass casualty incident plans are integrated, we have identified some opportunity for improvement there, and we're working on that from not only for mass casualty incidents, but just to increase mutual aid in general. It's interesting, in our state, the fire service has a very robust mutual aid plan. So if there is a 6-alarm fire in a town in central Massachusetts, as those alarms go out in consecutive order, additional fire apparatus get added to those responses without anybody doing anything. It's just there are run cards and it's automatic, and we've recognized through this work that that's not the same in the EMS world, and it would potentially really benefit from some enhancement in that area. And then communication. So in our state, in Massachusetts, in the different regions, the communication between emergency medical services and a central answering point is not necessarily always the same, and we're looking at some coordination there. I mentioned the American Burn Association earlier. We're fortunate to have several members of the ABA's leadership team on our group. We think that expanding burn care and access to burn experts is really important, whether that be done through telemedicine, putting a burn expert in a medical emergency operations center during an event with a lot of burn injuries, and really also leveraging this group for education, making sure that in addition to our trauma centers, we're able to ensure that all community hospitals and other organizations who need them have access to the austere burn care guidelines that are put out by the ABA and are involved in the work that they do to make sure that people have the education that they need. And we're also working with BARDA on some discussions they're having on burn care now. So lots of exciting work happening in burn care. And I think a really important part of what we're doing, given the significantly limited number of burn surgeons and burn experts throughout the country. We have several groups focused solely on vulnerable populations. I'll start with pediatrics. So there is work underway in the state of Massachusetts through this project to look at pediatric capabilities and how those capabilities are classified, also working with EMS for Children to look at care capabilities so that we can appropriately discuss care distribution during an event and really understand which facilities can take care of which pediatric patients. I'm sure we're not alone in this, but if you look at all the hospitals in Massachusetts, the age cutoffs for children who can be cared for in different areas of the hospital, or people who can be cared for in different areas of the hospital, are not the same. So in some places, a pediatric unit will take an 18-year-old, but not a 19-year-old, and in some places that's different. So looking at those cutoffs and seeing if there's any opportunity to understand them better and or standardize. And then working with the American Academy of Pediatrics on telemedicine options for pediatric experts during events. We have a group looking at behavioral health. That work right now is focused on trainings and tools and checklists to provide to behavioral health facilities before events so that they could enhance their emergency operations planning. This is one, all of our groups are impressive, but this group, I think the people we have working on are really just doing a nice job of thinking creatively about how to further enhance and integrate emergency management planning in behavioral health. There are groups looking at hazardous materials and radiation hazards, and there's a few key takeaways from here that I think are just kind of neat. It's amazing sometimes what happens when you put people in the same room who normally wouldn't be in the same room. So we're fortunate to have a robust hazmat team at the state level, and the director of the state hazmat team is very involved in leading this group. And putting him in the room with hospital leaders and emergency management representatives from healthcare organizations has been really interesting and really, really helpful. We've learned that there's a statewide hazmat conference every year that has not targeted healthcare before, that we can definitely include healthcare in, but it was just never kind of considered or pushed. There's currently an effort through our Department of Public Health to assess and potentially replace mass decontamination units that were provided to hospitals many years ago. And I think this group will be able to hopefully inform that planning process. And there's really an effort coming out of this group to make sure that hazmat and radiation experts can be accessed and integrated into the response structure to provide expert advice to clinicians when necessary, to kind of increase the quality of care provided. One of the specific things this group is looking at is trying to distribute the recent HHS guidance about hazmat decontamination. And in our state, it's not every hospital has a robust hazmat response decontamination team. It's kind of a very hard capability to maintain, especially if you're a smaller facility with limited funding and frankly not a lot of incidents where you have to decontaminate people. But we know from this guidance and other research that simply disrobing somebody who's been contaminated removes up to 90% or more of the contaminant, and trying to take that knowledge and spread it throughout the healthcare infrastructure is kind of exciting and interesting work. It's a group looking at high consequence infectious diseases that is leveraging some of the work done here at Mass General and through the National Ebola Training and Education Center, which obviously Nebraska is a huge part of as well. Thinking about ways to make it easier for healthcare facilities to have access to information about infectious diseases, high consequence infectious diseases, the areas of the world that they're currently active in, and then providing some background information about how all hospitals can improve their planning process to identify and isolate these patients when they come into their facilities, and how they can have the right types of coverage available, clinical coverage available to take care of these patients. I mentioned vulnerable populations a little bit earlier. There's a separate vulnerable populations group, and one of the really exciting ideas they have come up with is to actually make a position in the Medical Emergency Operations Center. We're hoping to move forward with this, focus solely on the care of vulnerable populations during an event. This is not something we have now, and frankly, something I think that we probably need to think more about and during event response, not just in the recovery process. So I think this is a really exciting development, and I look forward to seeing it play out. And then working on messaging and education, both to the populations that represent vulnerable patients and to providers who care for them, to make sure that there's proactive disaster planning for these groups. Telemedicine is a huge part of this project, and frankly, just a growing part of healthcare. I think it's exciting. There's a lot of opportunity to think about how we could integrate telemedicine into our Medical Emergency Operations Center and expand access to people like burn surgeons or trauma surgeons or pediatric trauma surgeons during an event, to make sure that expertise is getting to areas and hospitals that otherwise might have a hard time accessing it in rural areas of the state or rural areas of our region. There is, however, a tremendous amount of work to do. So there is a lot of technology, obviously making sure that protected health information is just that, protected in this environment is important. Making sure that we're addressing the issues around credentialing, liability, malpractice coverage. Those are all things that we're involved with discussions with our State Department of Public Health about. And we're going to be doing some mini exercises, testing this in the next few months, and then we'll be including telemedicine in our functional exercise for the partnership at the end of the summer. I want to say a few words about our Medical Emergency Operations Center. So currently in Massachusetts, the Department of Public Health has department operation centers they staff during emergencies that could affect healthcare, and then the Boston Public Health Commission, just picking Boston as kind of the biggest urban area, has a medical intelligence center, which right now for our region in Boston is where hospitals dock into. So we have a lot of policies and procedures and protocols that exist, and we are building off of those. The thought at this point is that the MEOC, Medical EOC, will be co-located with the Department of Public Health in their operations center, and we'll build off a lot of these strategies that have been used for both the DPH, Department Operations Center, and the Boston Public Health Commission Medical Intelligence Center. And again, we are working with our state partners on the issues that come along with this in terms of liability, who owns people when they respond to a medical emergency operations center, et cetera. This is a kind of early preview draft of what we think an org chart for a MEOC might look like. So this would report through our Department of Public Health. As I said, we're trying to integrate with and add to existing response structures. Be staffed with an EOC manager who is somebody quite familiar with emergency preparedness operations, and a chief medical officer, a physician in charge of the overall clinical response, supporting 4 major group supervisors focused on telemedicine, the way patient move throughout the system during an event, medical planning in general, and then our teams, if deployable teams are activated as part of the event response. In terms of deployable teams, the majority of our work to this point has been focused on working with the Department of Public Health to see what's possible in terms of mimicking the NDMS model, where basically people become intermittent federal employees when they're activated. And at the state level, if states don't have this legislation, it has to be drafted, and that's something that we're working through with our state right now. It'll be very hard, impossible to get that done by the end of this project period. So in the interim, we're looking at a host hospital model where we are encouraging and working with a few hospitals in the state to step up and potentially host these statewide disaster teams. So credentialing and licensing would run through the hospital, but activation would be run through the Department of Public Health. So it would continue the close relationship and collaboration we have between healthcare institutions and our Department of Public Health. And all the work that you would expect related to this is ongoing. So the same issues of liability, credentialing, malpractice, medical direction are all things that we're working on. One of the really interesting things we found during this work, one of the first things we wanted to do, of course, was to learn from others. So we tried to figure out what other states who had teams active or had their own state teams in the past, what they did. And we were unable to find a list of that anywhere, even working with our partners at ASPR. So we partnered with the Association of State and Territorial Health Organizations to send a survey out to all the public health emergency preparedness leaders across the country. And that is about to go out, and we'll ask them to give us information back about any state teams they've been involved with that will hopefully inform our planning process. So other things we're working on, we have an executive committee that has met several times and helps guide the strategic direction of this project. Although, as I said, we are focused very much right now on Massachusetts, which is kind of what the grant requires of us. We are collaborating with the other states in New England in our region on a regular basis and asking for their feedback. We've also had some discussions with people who applied for the RDHRS pilot project but did not receive it, and that's been really helpful in terms of relationship building and learning what they went through putting their grant together. I think just the process, and I think Dr. Lawler would probably agree with me, I don't want to put words in his mouth, but the process of just putting this application together and submitting it was robust enough that we learned a lot just from that. And it's really interesting to talk to other people about it. So we're moving forward as quickly as we can with our work. As I said, the majority of the output is really related to those SME groups that we went through in detail. They are focused very much right now on solidifying the gaps that have been found and identifying recommendations within the reporting, within the grant period. Medical teams and the medical EOC, the work continues, as I mentioned, in some level of detail. We are starting to plan in earnest for a pretty significant functional exercise to test all components of the system that we're trying to develop, which will be held at the end of August. And of course, there's a significant report that we'll have to put together at the end of all this to submit. And I mentioned metrics before. I think it's worth mentioning again. Our work with the School of Public Health is really important to make sure that we're collecting data and that we're using that data to inform the process in the future. So I know that's a ton of information in a relatively short period of time, and that's the end of my formal presentation, but I believe we're going to move into Dr. Lawler's presentation, and then I'm happy to answer questions at any point.
Thank you, David. I appreciate you taking the time to inform us on all of the really cool things that you're doing in Massachusetts and beyond. I think I would like to hold the questions till the end, because I think that if you have one question for one person, you may end up with the same question for both of them. So let's just move on to Dr. James Lawler, who again is from Nebraska Medicine and the other partnership in this project. So Dr. Lawler, are you on?
I am here.
Excellent. And are you good with sharing the screen, or did you need, oh, looks like you're good.
All right, look at that. I have conquered technology.
Fabulous. Thank you.
All right, thank you, Christy. So again, I'm James Lawler from Nebraska Medicine and the University of Nebraska Medical Center, and I'm really thrilled to be a part of this this project. It's been very exciting to work with Dave and Paul Bittinger and the entire Harvard team, and we've had a chance to speak with them. And I think that's one of the benefits of this project is, I think Asper. I will give them credit for purposefully selecting two institutions that took very different approaches, and I think that that's been really helpful to look at how others have approached the topic. We've learned a tremendous amount from those conversations, and also I think it provides a greater diversity of ideas and potentially experiments in how we can enhance regional health system responsiveness. And I think that that's going to be really critical moving forward to figure out how you can then generalize this to many different regions, because obviously all of those regions are going to have their own unique needs and idiosyncrasies, and there's not going to be a one-size-fits-all solution. So if you'll notice, our project took a little twist on the Regional Disaster Health Response System name, and we called ours an ecosystem, and that was purposeful. So the Nebraska Regional Disaster Health Response Ecosystem is what we call our project, and that reflects the philosophy that we took going into this project. So everybody here has eventually ended up calling this project nerdy, based on the acronym. So we've kind of embraced that now, and we are preparedness nerds looking at how we can change the paradigm of how we do health system preparedness. And one of the things that we wanted to address going into this is the fact that health systems really are on an island in many ways in terms of bearing the responsibility, along with pre-hospital first responder emergency preparedness communities for being able to absorb and manage large-scale disasters without really having the infrastructure or even the business model to be able to do it. Everything within healthcare, in recent decades has focused on improving efficiency and shrinking size and moving towards just-in-time supply chains, and all of those things do create a more efficient bottom line in day-to-day operations, but they also make the system more fragile. And at the same time, we're asking health systems to do more in terms of preparedness and being ready for these disasters. And so there's a disconnect there. And so trying to break out of that is one of the things that we really thought was important for this project. The other dynamic is that most of the programs and most of the funding really that supports these types of efforts on a hospital level and at a health system level come from government programs, which are unreliable sources of funding. They vary from year to year. Their direction and their goals often change, and having an external factor like that drive what should be an inherent and internal process sometimes doesn't work. And additionally, the amount of funding that goes into this from the federal level, for instance, is really just a drop in the bucket compared to the $3 trillion healthcare industry that is what delivers healthcare on a day-to-day basis to Americans. And so expecting $300 or $400 million of funding to be able to move the needle in a system that large is probably not realistic. And so our thought was, how do you create a system that really from the inside generates an impetus for additional preparedness efforts and for building it into the fabric of how the health system operates. And that's where this idea of an ecosystem came about, where it's really a self-sustaining community, as you can see from the definition of ecosystem there. And so some of the characteristics that we are trying to impart in health system preparedness are being inclusive. So looking outside of just the traditional stovepipes of healthcare delivery and emergency management to incorporate other components of the community that can have a significant impact in being able to expand health system capacity to manage large-scale events. The second thing is trying to create more connections, right? So that's one thing that ecosystems are really built on, these feedback loops of information sharing and action and reaction. And so the more information leveling platforms we can have, the more communication we can have in real time, the better the system will operate. Redundancy is another is really another component of nature that we often try to eliminate in human systems because of that efficiency equation. But the redundancy builds in a tremendous amount of safety factor when systems are perturbed. And that's what we want to try and build into the health system. That idea of a dynamic system, so a system that can change in response to the external forces that are acting on it, is another thing that we think is really important. And finally, this concept of being self-sustaining. And this is really finding the economic incentives and the bottom line equation, not only within the health system, but within the community writ large, including and especially including the private sector, businesses, insurance companies, and all of those that actually benefit from enhanced preparedness in terms of reducing risk and ultimately, potentially economic consequences of disasters. Where is the threshold for them to be willing to invest in preparedness that actually improves their bottom line? So these are all concepts that we tried to weave into this regional project as we've been moving forward. So our goals, really are not necessarily that different from what many people have discussed in this realm. So, first of all, integrating response capabilities across the health system, but as I mentioned, also including community assets outside of traditional health system and first responder and emergency management entities that can be leveraged to improve both timeliness and also capacity of response to be able to manage large-scale events. Expanding specialty care expertise, which I think you've heard from Dave. The Mass General folks have done amazing work in that, and we've learned a lot from them already in how we can improve what we've been trying to do. That coordination idea, which not only incorporates that integrating piece and planning, but also the information sharing and situational awareness component, that to have a coordinated response, you really have to have very good situational awareness across all of the entities that are involved. Looking at measures of preparedness, so ways that that communities and organizations can actually assess how well they're doing and understand where they need to make improvements, and also understand how those improvements are impacting some of those economic consequences. And then finally, our approach is really built upon a lot of work that's already been done across our healthcare coalitions. And just given the geography and demographics of Nebraska being a very rural state, we thought our healthcare coalitions were a really good way to base our approach. And we'll talk a little bit about that later. So we basically broke the project up into 5 capabilities. That's based on the capabilities that were actually outlined in the ASPR announcement and guidance that was sent out. Capability 1 is looking at creating a network and a governance and connection structure, so bringing in all of the various entities that need to play, and having an organizational structure that allows the project to move forward. Capability 2 is really looking at aligning plans, policies, and processes. Capability 3, it really focuses on statewide medical surge capacity. How do we increase the capacity of the system? Again, both inside traditional and incorporating non-traditional elements of communities to be able to manage surge capacity beyond kind of the standard 120% that everybody kind of plans for and has a decent shot of achieving. But beyond that, the system really starts to break down. Capability 4 looks at improving those those lines of communication and information sharing platforms to create improved situational awareness. And finally, capability 5 is really looking at that metrics and assessment piece, and then exercising what we've developed to demonstrate A, what capabilities we've achieved, and B, where gaps still exist. So some of the highlights to date, I'm not going to go through everything we've done, but I think a few are worth noting. First of all, in that whole of community effort, we've really found a lot of pockets of activity going on in the state of Nebraska that we really weren't aware of before, and had no connection into health system preparedness and the activities of our healthcare coalitions. This is everything from some of the work that our United Way is doing with business preparedness, and also in operating the 211 call center, which is a statewide information call center that United Way runs, but hasn't really been plugged into health system preparedness and public health emergency response. Also the University of Nebraska Extension Service, which is kind of a agricultural extension service on steroids approach, where they really look well beyond the ag sector into business community preparedness efforts. A lot of things have been going on in those spaces that really weren't connected to some of the health system preparedness efforts, and have started to really create opportunities for linking existing efforts rather than having to create new ones. The Clinical Disaster Risk Assessment workshop is a workshop that happened in Lincoln in December. It was really the first opportunity to bring folks together from all 6 healthcare coalitions across the state to start looking at some gaps that exist in health system preparedness and response. It was focused on 3 different scenarios that kind of gamed in a tabletop way, how the systems currently work and where we need to make improvements. We've also been working on looking at existing local and especially state legal frameworks that exist for health system response, and where some of the gaps are there, and creating a reference guide for state and local officials, and also kind of a to-do list of things that we can potentially address at the state legislative level to improve ability of hospitals and healthcare coalitions to work more effectively. Developing statewide specialty response teams, again, reflecting a little bit of what Dave talked about with his folks at Mass General. And we've also developed a new health system surge response model in collaboration with Oak Ridge affiliated universities. It's a nonprofit organization that's worked extensively with CDC in developing workshops and response plans for a number of public health emergencies, particularly related to pandemic preparedness. And so they've been an important component of our team working on developing healthcare surge response models. And we'll talk a little more in detail about the metrics and readiness assessment program that we've been developing, and also the implementation of Knowledge Center, which is a information sharing software platform that's been going on across the state. So this metrics and readiness assessment program, as I mentioned, that's in capability 5, and really focuses on how do we know how prepared we are and what we need to do to improve, and how do we build that into incentives to create, again, those forces that drive internally organizations and communities to make investments in preparedness. And so, we've done both a development process for metrics themselves based on extensive literature searches and looking at what's already been done, trying to find those key indicators of preparedness, and then developing a program that would essentially allow self-assessment and self-regulation of the system. So hospitals and communities looking at their readiness through annual peer review consultations, which develops preparedness reports and action item lists, which could be submitted to authorities like ASPR to achieve readiness response designations. But those designations could also be important influencers in either credentialing or even in reimbursement schemes. So, ultimately, eventually, the holy grail would be to build this into CMS reimbursement schemes so that hospitals and communities that have better response readiness designations get some additional incentive through higher Medicare, Medicaid reimbursement schemes or other financial models that actually allow those hospitals and those health systems to benefit from those designations, and also obviously help the community then to benefit from improved readiness and improved outcomes, not only in large scale disasters, but I think in day-to-day practice as well. And so that's something that is an ongoing process of developing that cycle and those metrics. The next thing I wanted to speak about was this Knowledge Center implementation. So Knowledge Center, as I mentioned, is a commercially available software platform that was essentially allows organizations to share information in real time. And what Nebraska has ended up doing is really making an open access to Knowledge Center that is being implemented in kind of two compartments that are linked and talk to each other. One is in the healthcare compartment, and the other is in emergency management. So in healthcare, Knowledge Center being implemented across all of the healthcare coalitions and partner hospitals and other organizations you can see here allows for information sharing in real time of operating status, of logistical needs, of emergency activities going on, that allows that situational awareness that enables the system to more effectively respond. In the same light, in the emergency management space, Knowledge Center is going to link not only the State Emergency Management Association, NEMA, but also a number of other state governmental organizations, the State Patrol, the State Information Analysis Center, Department of Corrections, National Guard, all of the major players involved in emergency response to be able to, share knowledge of asset location and tasks and all across the board, and then be able to synchronize that information with the healthcare space as well. So all of our partners in this are very excited about the implementation that's already started in Knowledge Center, and we have a series of workshops that are ongoing to start training people on how to use it and how to incorporate it into their day-to-day business. That's really one of I think the key factors in Knowledge Center being successful is it's not a break the glass system that only operates during emergencies. It's a system that allows this type of information sharing and coordination on a day-to-day basis. And so people should be using it in their day-to-day jobs, and that means that they'll actually use it during emergencies. Some future activities to highlight. I'm actually right now at at the first Coalition Surge Workshop, which is being held in kind of the large Northeast region healthcare coalition that has a large rural and frontier area of the state incorporated. And these workshops are really looking at hospital and healthcare coalition surge plans, everything from pre-hospital care to transportation to hospital acute care to disposition. How do all of the pieces within the healthcare coalition fit together? Where are there opportunities to use some of those external entities and resources to build into an improved system? We will have, in addition, ongoing actually is kind of a modeling, large data set modeling analysis to help with some of those surge plans, looking at triggers and indicators for different standards of care and different operating plans based on level of resources and the level of the disaster, switching gears from kind of your day-to-day activities to crisis standards to kind of catastrophic standards of disaster response. We're going to have in August a full-scale exercise. It's going to be a statewide exercise of a lot of these different plans and activities, focusing on 2 of our regions and healthcare coalitions, looking at a large complex disaster. And then finally, our public-private partnership outreach is ongoing. So bringing in additional stakeholders from the business community, from insurance providers, of which Nebraska and Omaha has actually a pretty significant component, looking at these economic incentives and hopefully doing some additional quantitative analysis about where the price points are for these investments in preparedness that allow many of these activities to be self-sustaining and ongoing. The last thing I'm going to talk about is kind of our matrix, which is something that we've put together to kind of guide these activities and what we want to do, not only in this year but ongoing afterwards across the top. In that red row are the themes that we really want to focus on developing. So developing a self-organizing medical response is this idea of this ecosystem that can self-actuate and actually start to move and respond on its own without requiring a specific top-down direction. Developing a tiered casualty management system that enhances surge capacity. This is in some ways modeled on how the Department of Defense does combat casualty management, creating a tiered system that allows rapid triage and management of cases, in much higher volume than your normal system would allow. Then just expanding the entire capacitance of the health system by pulling in a lot of these additional resources in the community at large. And finally, this idea of improving or increasing penetrance of specialty care expertise and capability down to the local level in the midst of a disaster. Down the left side in that first column are what we think are enabling factors. These enablers are what will allow us to eventually achieve these goals in the themes and in the overall grant, 5 capabilities as well. The first is this idea of, pulling in these additional components of the private sector and community, both public and private organizations, to be key parts of preparedness and response. Number 2 is, maybe the most important, is finding those economic incentives and being able to quantify them, and then figuring out how to use those to prompt appropriate investment in preparedness across communities. The third is local and regional adaptive planning. So how do you create plans that are not fixed but are responsive and can are dynamic and can actually change based on the minute-to-minute realities on the ground. The fourth is building education and training standards into communities that facilitate a lot of these themes. And finally is the idea of the specific technologies and platforms themselves. What are information sharing platforms such as Knowledge Center that can be used to level the information playing field? But we also want to look at a lot of other creative solutions that have been employed out there, including social media platforms, which in many disasters have been shown to be one of the most effective tools for information sharing, certainly among the public. Even down to things such as ham radio operators who, in catastrophic emergencies, when cell phone, mobile phone towers are down, could provide that information network as a backstop. So those are all of the enablers and themes that we're trying to incorporate into everything that we're doing. And with that, I will wind up. I think we have still a few minutes left for questions, so I managed to get through a little quicker than planned. So thanks very much for your attention.
Thank you, Dr. Lawler. If you have audio, feel free to go ahead and unmute your microphone and ask questions if you have them. If you are if you only have chat, feel free to put them in the chat box. Your chat box should be towards the bottom of your screen, depending on how you have it set up or what kind of computer you have. I think that it's different on a Mac versus a desktop as well. So Does anybody have any questions? And thank you for sharing, James, Dr. Lawler, for sharing all of the really cool things that are also happening in Nebraska as well. I think that the difference between the two areas, between Boston area versus the Nebraska area, is really going to give some great ideas and insight to Esper on how to progress and move this whole system forward. Any questions?
Everyone is just stunned into silence, Christy.
Dave Reddick has a question for, I think to probably to both of you. What was most surprising so far? What was your most surprising thing that's happened within this project?
Dave, you want to go first?
Sure. I can think of a few surprising things, and both of them I think I've already referenced, unfortunately. But one is just, and it's very simple, but the value of getting the right people in the right room and making time to have the conversation. Some of the issues, the solutions I mentioned with our state hazmat team and hospitals, and making that relationship more robust, I think is really, really impressive and helpful, but obviously very simple. And then we were a little surprised when we started looking in detail at state level disaster medical response teams that there really is no central accounting of those teams and where they exist and best practices, and hopeful that we're able to put something together that's helpful for other parts of the country as well.
Yeah, so I think from our end, one of the most surprising things was, and again, I touched on it a little bit in my presentation, is how much is going on across the state in different pockets related to preparedness, and even touching a little bit on the health system preparedness that's not plugged into some of the larger programs like the HPP or FAP, and have been kind of going along in parallel. And so it was great to actually see and know that some of these other efforts are ongoing and we can start to pull them in. But it was just it's always puzzling to see how many of these things can be going on, and not have other people aware of them. And after 21 years in the military, you think I wouldn't be surprised by that type of thing, but I was.
I get surprised by that too. I hear a lot of that through AHAP from across the country, from one program to the next. That's interesting. Here's a question for Dr. Lawler. I noticed that Nebraska has a crisis standards of care guidelines. It's available to share with others. I was one of the contributors for Utah's crisis standards of care guidelines. It's available through Utah's Hospital Association website under emergency preparedness resources. It was a 5-year project, which was finalized as of last week. Oh, that's not Stephen Rosberg, from Steve Ikuda, but does Nebraska have the ability to share the crisis standards of care guidelines too?
Yeah, so Christy, if you can get Steve's email, I will get back to him and see what I can share.
Definitely. I do have that. And we will also put a link to the Utah's crisis standards of care guidelines on their hospital association website. I was actually just looking through those the other day. Any other questions? All right, I am going to call it a day, I think. Thank you very much, both Dr. Lawler and David Reisman, for sharing your time and teaching us about all the efforts that you've put in so far, and all of your insight into some of the best ways that we can move forward. We appreciate that.
Thanks, Christy. Enjoyed.
Thank you.
Thank you, and have a great day for the rest of you.
Take care, everyone.
All right.
Bye-bye.
Bye-bye.
Bye-bye.